have not been doing. Here are the learning objectives for the series. We are fully accredited for 2 hours and no one has anything to disclose related to their topics that we'll talk about tonight. There is no charge for this activity. I will send out an evaluation afterwards, which will serve as your key to credit. So make sure to keep an eye out for that in your email and fill out that Qualtrics, which will serve as feedback for our speakers, as well as your key to CE. And with that, I will turn over control to Dr. Hall and Dr. Pon to start their piece.
All right, thanks, Dexter. So good evening, everyone, and thanks for inviting us, Dexter, to give this talk. I think Brent and I have been on a circuit now, it feels like, with this talk. My name is Tiffany Pon. I'm an associate professor of clinical pharmacy with UCSF School of Pharmacy, and I'm the experiential program director for the Greater Sacramento Area program. And honestly, this whole idea was Brent's idea, so I'll let him introduce himself.
Hi, I'm Brent Hall. I am a clinical specialist in pediatric pharmacy at UC Davis Health. I serve as the PGY2 pediatric residency program director. Yeah, you're right, Tiffany. This will be our third time, I think, given this, and we've had to give it in different ways every time. So,
yeah. So maybe this one will be the best way.
Indeed, indeed. We'll get it right one of these days.
Oh, yeah. All right. So these slides obviously have been used before, so we have nothing to disclose. These are the specific objectives for this particular talk. So we're going to go over how to identify pros and cons of traditional preceptor-led topic discussions. And by traditional, we mean the attending pharmacist-led discussions where they're really driving the discussions, more like a lecture type experience, where they're giving information to the student or to the learner. We'll also summarize the benefits of perhaps using a flipped classroom model in the experiential setting, and specifically to develop a tool to guide flipped classroom-based topic discussion preparation. And that's really what the majority of the time will be spent on, is kind of guiding you through how to create a tool that you can use for your own rotation. We'd like to get started with just a question for you to respond to, maybe in the chat, just to get you thinking about efficiency and efficient teaching. So aside from your clinical duties, what other work responsibilities do you have? Give people a few seconds to enter in anything that comes to mind. Resident evals, yes. So definitely part of teaching. I feel your pain there. I'll let people kind of shuffle in some of their comments there while I'll move on in the slides. So when we think about our roles or our professions, we obviously have those clinical pieces where we're doing order review, verification, patient visits, patient education, clinical monitoring. Those are the things that we think about. And then we have the other category. So many of us have administrative responsibilities. We also are usually asked to be involved in some sort of committee or some sort of institutional group. And sometimes we're asked to be in scholarship and research, even if we're not in an academic medical center or not in academia. And you'll know that all of these items kind of fall into the ASHP qualified preceptor bucket in terms of filling things out for your preceptor record. So in looking at the chat, it says support P&T, data analysts and quality improvement, policy development, utilization review, and then precepting or teaching. So in one article that kind of tried to pull pharmacists and really break down what they were doing, they found all of these things. So all of the things that you're doing, the daily rounding, the committee involvement, med-rec, clinical monitoring, didactic lecturing, patient education, order verification, research and publication, admin, precepting, and it's a lot, and it can be a lot. So that leads us to the first question to think about. So which of the following subjective factors is associated with pharmacist burnout? A, too many clinical duties, B, inadequate time for teaching, C, junior faculty rank. or D, male gender.
Sorry, I might have launched that a little early.
That's okay. We actually don't need to do polls if you don't need, it's more just like a thought thing. All right, so we'll go ahead and answer that in the next few slides. But for those of you who are familiar with burnout, you probably already know that the three core components of burnout include exhaustion, depersonalization, and lack of accomplishment. When we're talking about pharmacists and the studies that have been done in both academic settings as well as institutional settings, exhaustion and depersonalization are the big components that are commonly found in pharmacists who feel burned out. In faculty, they found that predictors of burnout included women, gender, not having an outlet or a hobby or a mentor, being earlier on in your career. So as an assistant professor, those individuals are usually entering their career very, very engaged and excited to be there, and typically take on a lot early on, and then that really leads them to burnout. And then also having young children, as I'm sure a lot of you are familiar with, having two small children myself, it's almost like having two full-time jobs when you come home. So those are not too surprising in terms of being predictors of burnout. In a study looking at hospital pharmacists and subjective factors associated with burnout, these pharmacists documented or reported that having too many non-clinical duties, so that other category, having a lot of administrative activities, and then also inadequate time for teaching. So those were all really positively correlated with higher burnout scores. So what have we done to really look at how to navigate maybe making teaching and these non-clinical things a less of a burden? One of the practices is using the layered learning practice model. I know that many of you are familiar with that being at academic centers, but just as a brief review, the layered learning practice model includes or models after the medical education model, where you have your attending physician, your fellow, senior resident, interns, and then students below them. And so for the pharmacist layered learning model, we have the layer one of the attending pharmacist. So they're really overseeing their rotation. They're on record as a preceptor. They're responsible for the formal evaluations, grades, and ultimately responsible for patient care. In layer three, we have the student pharmacist. So they're kind of boots on the ground, trying to absorb as much as they can, actively participating in patient care, reporting to the resident more often than the attending, providing feedback to that resident on teaching, et cetera. And then we have that middle layer, which I would argue is probably the most important layer, since they're the glue. And a lot of the responsibilities get placed on them. So they can be expected to be the primary preceptor for the junior learners. They are also learners themselves, so they're actively participating in the direct patient care activities. They're trying to learn how to be a preceptor, so they often are pulled into coordinating the learning activities and orientation, and then also providing feedback. And so when we're thinking about utilizing these, how well prepared are they? That becomes a question, which is our question 2. True or false, most pharmacy residents feel prepared to lead topic discussions with students. So it's kind of a leading question, as you guys probably can guess that not very many. Haley Burhans, who is was one of our residents and is a ED pharmacist at UC Davis, says false. So yeah. So there are lots of challenges with layered learning. I think it can be effective when you have the right structure in place, but some of the barriers to really utilizing layered learning is misaligned schedule. So sometimes you may have a resident that's less experienced than the student, right? Especially with a new curriculum with UCSF, the students, the APPU students kind of almost start at around the same time residents, but before then they were starting in April. And for sure they had, 3 rotations under the belt before the PGY1 started. And that was definitely a situation where residents were a little bit intimidated in those settings. You may also have varying levels of interest from your residents in terms of being interested in the teaching or competency in precepting in general. And then you have maybe the potential for decreased individualized attention for the resident, because like I said, they are learners. They need something that's going to boost their learning too, and not so much just catered to student learning. And we did a little study that we're actually going to have published in Hospital Pharmacy soon, looking at resident perspectives of the layered learning model and sources of stress that come with precepting without some structure. And they reported that quantity and depth of topic discussions was a source of stress, so indicating that they didn't feel very well prepared. And then also just expectations, so a little bit of imposter syndrome there, right? Just student expectations of their knowledge and how they need to perform. And then on the other side, we have preceptors, so our attending level preceptors who have been doing this year after year. And this is a direct quote from one of our preceptors just saying, learners are coming in every month, the same topics are being discussed over and over, taking time from our other duties and our both clinical and other categories. So what can we do to kind of mitigate this and figure out some tools to really provide structure, but also really engage residents in the learning process and students in that learning process too? And this is where our Brent's idea for a flipped topic discussion comes in. It's really a tool to utilize in layered learning. And what a flipped topic discussion is it really puts the onus on the learner. So you create this structure in terms of a guide that has specific objectives for the particular topic. And then it will also have the required readings. And so everybody from preceptor to learner is aware of what needs to be covered in that topic discussion. They're also aware of the time frame that they are supposed to complete this topic discussion for. So is this guide for a 15-minute versus 20-minute versus an hour-long discussion? And they all go into that knowing it before they even start it. So the benefits really is that it drives the self-directed learning. There's standardization because it ensures that learners are really touching on the concepts that you think are important. And all the preceptors, from resident level preceptors to attending level preceptors, are setting the same expectations. So this is really good just even for a team taught setting. And you can have residents from all backgrounds facilitate because they can do the same amount of preparation for that. Now, the flipped model in the literature is pretty sparse, non-existent for experiential. Most of the literature and evidence is in the didactic setting. And in that setting, even the outcomes are a little bit controversial. So in some studies, they did show that it improved performance on formal assessments, but there's no real data on long-term retention of material. And my suspicion is that it's because a flipped mode of teaching really requires application. And in the didactic, you have your hit or miss on when you're going to apply some of these concepts and how consistently you're going to be applying them from day to day, week to week, month to month. But in the experiential setting, you're applying every day. And so I think this is why flipped techniques are probably going to be pretty effective in our experiential setting. And so with that, I'll hand it over to Brent to even give you more reasons for using a flip model in experiential.
So part of the reason for coming up with this concept was the fact that when I'd be giving that same talk over and over again, I can definitely reiterate what that one pharmacist said. You feel like you're saying the same things over and over and over again, month to month to month. And the other aspect of it that I was struggling with was the fact that you spend all this time going through and setting up foundational information for the student, but you don't get to talk about any of the fun stuff or the nuanced things that go along with those topics because your time is really taken up by the fact that you have to set that foundation. And anybody who's given a lecture, especially in a didactic setting, knows the glazed look that you start to get from the people that you're talking to, the difficulty in keeping attention. So there was a lot of time there where you're giving this kind of informal lecture, so to speak, and that they're not catching all of it. So I felt like we weren't doing a great job of really establishing our bread and butter information for our students and for our residents. So we needed to come up with a different way to do it. So why try this flip model in experiential training? And what we're really trying to do is move this direct instruction from the group space to the individual space, and it allows for this dynamic and interactive learning environment, this change in culture, intentional content, and the educator can guide the application of concepts in the group setting. So I'll break that down into what FLIP stands for. So F is this flexible environment. This environment is flexible in its expectations. It's flexible in the space of when and where the students choose to learn. This does not have to be in a classroom. This can be outside on a bench if you want to take everybody outside for some sun and such. You're able to move it around. And it also can change with regards to the level of topic that you're going to discuss. It allows for you to have the basic foundational issues set up for this FLIP discussion. And if you're talking to a PGY2 learner who's going to want more information and more nuance, is going to have a better background, it allows you to kind of mold that in real time so that then you're able to address those higher level questions. Or if you're working with a student who's new to the entire area, you can really focus more on that kind of foundational thing. L is for the learning culture, and this shifts the learner to the center of this discussion. So the learner is engaged throughout this entire process. It allows for them to have autonomy. It allows for them to be empowered. And it changes the culture where they are at the center of the lesson. They are teaching you. So they are engaged throughout this entire period. Should you have a layered concept, you're going to probably have, if you have a student, a PGY1 and a PGY2, maybe the student's doing some of the questions, the PGY1's doing some of the questions, the PGY2 is kind of overseeing it. There's lots of different ways that you can move this around and change it to give different people different experiences as to what it is like to precept, how to handle topic discussions. And it also gives them a fallback point where they'll have the basic information. So even if it's not a topic or an area they know all that well, they can still feel fairly prepared for it because they'll have done this background reading before they've come in. Intentional content is going to allow the educator to help the students develop this conceptual understanding, what they will teach and what they want students to explore on their own. We can give them those objectives, but this allows for you to take that, foundational and then to actually kind of apply it to things that you've seen in practice, or perhaps a patient that we're talking about, because we try to have our topic discussions coincide as much as possible with an actual patient with that disease state. So it allows for us to then do that application more so in real time. And then finally, it does require you as the educator to continuously observe. Unfortunately, you are not able to leave and get that hour of your time back. You still need to be there to make sure that the comments that are being made, the interpretations coming from the papers that you've given them, all of this makes sense and it's in the right context and such. So it's still very important, but instead of you being the active person, you become the passive listener who's just kind of going along and making sure everything's going in the direction you want, and then interjecting as you can with, whether they're asking questions or you want to bring up a specific topic. This improves your efficiency of time utilized. The big front-loaded energy is the fact that you have to go and put this together. But once it's put together, then it's just kind of an annual review to make sure that your topics are still the appropriate ones, you're asking the right questions, and that your literature is up to date. Okay, Tiffany. So question 3, and this is again, you guys can think about it, throw an answer in the chat. Which of the following considerations are necessary when creating a topic discussion template? Select all that apply. A, the scope of the discussion. B, the time frame for preparation. C, the time frame for the discussion. And D, relevant objectives. So let's kind of go through that. So step 1, when you're trying to create this topic discussion, is you have to pick a topic and you have to decide, what are you going to discuss? And you want to make sure that this topic is not uber broad. So you don't want to have, the one that I always bring up is seizures. Now, if you're talking to a student and you just want to talk about pediatric seizures and basic information with regards to it, maybe that's one thing. But if you're at a PGY2 level, you may be talking about different types of seizures. You may be talking about newer, older anti-epileptics. You may be talking about infantile spasms. You may be talking about autoimmune encephalitis. You may be talking about lots of different issues. And those topics can, if you try to combine them all into one, become kind of a monster. And it's very difficult for you to cover all that information. So you need to get targeted with regards to what you're going to do. So instead of doing that seizure, maybe you're doing infantile spasm, or maybe you're doing ketogenic diet or something along those lines, a little more specified. you want to have a reasonable time frame for the discussion and also a reasonable time frame for the learner to prepare. So generally the way I think about it is most of the time we're looking at about an hour tops. And I have just seen that once we start going over an hour, people just start to lose attention. Plus, it's very hard to carve out more than an hour during the day, especially if you're working in the pediatric ICU or something along those lines, where you're going to get pulled in different directions. When you set up that hour, you then have to take into account how long are they going to take to prepare this. So we'll kind of get into those aspects as well, but you definitely don't want to send them home with, having to read the Encyclopedia Britannica so that then they can know everything and basically, read all night and then come in and just regurgitate it to you at that point. Next slide. So what I try to do when I'm starting to put together my objectives and my art is determine what articles I'm going to pull and what are the signature papers the learner must be familiar with to function at their level of practice. So I remember one of the first topic discussions I put together for, I had tried to combine heart failure with hypertension, and I think I had 14 articles that I initially had selected. And that's absurd. There's just no way that anybody is going to be able to go through that. So, one, split those up, two, get into more specifics, and three, what is kind of the seminal paper that they need, to read and that you want them to have from a background standpoint. So sometimes that is, a review article, sometimes that's a guideline. Sometimes that's, depending on what you're talking about, you could have that be kind of a landmark trial in that area if you're going to be that specific with regards to things. But you can also include supplemental materials. And my whole problem when I'm putting these together is I want to make everybody an expert in this topic. And it is impossible. I have developed this knowledge over years of practice. And for me to think that I can just do a matrix upload into people and say, boom, now you know everything about that is impossible. So I really have had to kind of come back, but I also want them to have access to papers where common kind of questions that I've seen will come up. And I can put those into the supplemental material section so that they can have that for their library. And should that ever come up, which you can touch on those aspects during your topic discussion, they can go back and read more about that specific, side effect or that specific scenario where they'd use this medication and such. But again, I'm not putting that on them to actually have to read all of that. I'm just going to have them read one, maybe two articles tops is my goal. So for the third, based on the articles you provide, you want to compose your questions or objectives that can be directly answered or addressed from the text. So once I've selected what I think is a good starting point for a learner at that level, I'll go through it and I'll kind of see, okay, how does this, go about? What are the questions that are being answered in this guideline or in this review article or in this landmark article and such, and really kind of focus my objectives there so that they can actually read this article and pull from it. Remember, you're then going to be filling in those kind of nuanced aspects, those questions or those interesting ways of practice or the different things you've seen during your practice and such. So it's not something that you have to, have them do 15, 20, 30 objectives during this discussion. You're going to try to isolate it down to like 4 or 5 things that are going to be fairly broad topics, but it will allow you also to bring up the information that you think is most important for them to take away from the actual discussion. And we like to use Bloom's taxonomy. I'm sure everybody's familiar with Bloom's taxonomy to compose the questions and consider the level of understanding you expect from the learners. So making sure that if you have somebody who's, more naive to this topic, that you're not asking those advanced questions. And everybody's seen the Bloom taxonomy pyramid. Obviously, the easiest or the lowest level is remember. That's going to be another way that you can refer to that as knowledge, and that's recalling and accurately remembering or restating information. Understanding or comprehension is how do you interpret that using your own words. Application, using that comprehended knowledge, how do you apply that in a practical situation? Analysis or analyze, deconstructing that comprehended knowledge into its constituent parts, indicating relationship and dependence. Evaluating, using that criteria to judge success, value, or quality and importance of work. And then finally create, which is contributing to society through the fabrication of new knowledge, comprehension, or application by building upon previous work. So it's going to depend on where your learner is, what you're trying to communicate in this topic discussion as to where you're going to be on this. But if you go to the next slide, We have our common words that we use in order to set up our objectives and our questions to help the learner and guide them and make sure they're answering questions that are appropriate for their level. Go ahead, Tiffany. Yeah, this one, trying to limit the topics on topic foundation. The discussion is so great because it allows for that more in-depth conversation. Sometimes it's nice to actually give a case when appropriate for student learning, like in that ketogenic diet. We commonly talk about what are the labs you need to get before you start a ketogenic diet? How do you introduce that? How do you advance that? So having a setup with a patient and having them kind of work through that can be really helpful. But it really just depends on the topic that you're doing. The other important thing to this is after you spend all this time putting this together and you've gone through, you're going to need to continuously improve it. And you're going to need to reassess and reevaluate what you're seeing. It's very unlikely that the topic discussion will be perfect the first time that you put it together. And one thing that's great is as the students and learners are going through the topic discussion, you can ask them to give you feedback with regards to it. Another thing that commonly happens is you've got an idea in your head as to how this is going to proceed, but then when you actually do it, it kind of maybe goes in a different direction. And you notice that maybe some of your objectives are out of order, or maybe there was something that you really didn't focus on that you really think is necessary, that you want to make sure that they're aware of. So at that point in time, you're going to be reassessing what you like and what you don't like about the topic discussion and moving things around as much as you need to. The other piece of it is annually I will go back through, or we divide it up between all our preceptors to go through the different flip discussions and make sure that our literature is still up to date and that we're still focusing in the right areas. Obviously, we'll have conversations as a group as to if we need to change tact with regards to, well, maybe this topic discussion isn't as helpful in this scenario, so maybe we need to develop something new over here. But over time, we have built up, my goodness, I want to say that we probably have 80 to 90 different flip topic discussions that we've put together over the past, 4 years, 3-4 years. So it's something that you have a lot of upfront with. It's nice when you have to give that topic discussion because it's already all set up and all the information's out there and it allows for that interactive discussion. But then on the backside, you have to make sure that you are revising and reassessing and making sure that it is as good as it can be. And then Tiffany, you can take it from there.
Yeah, so before we kind of split up into breakout rooms, we wanted to provide you with an example for how to create one of these topics going through the steps that Brent had just laid out. So the topic that we selected was just heart failure outcomes with SGLT2 inhibitors. So again, not trying to cover all of heart failure and huff rough, huff puff and all of that, but just really specifically SGLT2 inhibitors. The required reading is just one reading, so it's a guideline, and it will cover all the objectives that we'll list in a little bit. But on top of that, for supplemental readings, we direct the students to the actual primary literature and the studies that generated the evidence for using SGLT2 inhibitors for heart failure. And here are the objectives. And so in parentheses in the beginning, I just put what kind of Bloom's level each objective was. And so depending on, again, what Brent has referenced, how in-depth you want the topic discussion, what your goal is for the learner, you might be higher or lower on the pyramid. And it's just basically up to you and the topic as well. So first, remember, so describe pathophysiology of heart failure with reduced ejection fraction. Explain the mechanism of action. So these are a bunch of recall. But then we move into some evaluation. So assess the findings of the trials showing benefit of SGLT2 inhibitors. And then we have kind of a gamut. So analysis, examine proposed mechanisms for action, a mechanism of action for SGLT2. And then more remember and evaluation. I won't list or read through all of them though. So that's pretty much it. The focus of this talk is really to get you guys active and engaging with each other and to create an activity of your own that is helpful for your own rotations. So I would suggest take a screenshot of this slide so that when we go into the breakout rooms, you will have the instructions, but we would like you to select any topic that might be relevant to your group or to your practice setting, define who your learner is and at what stage of training they are at. Select articles you'd like them to assess or evaluate. So basically the articles that you would want them to read in preparation for the topic discussion. And then create the objectives that you think are central to the learner's understanding of the topic. You need to set your parameters. Like Brent said, like he mentioned, we rarely go over an hour for a discussion, and then probably no more than 2 hours for the learner to prepare. But those are the guidelines. So with that, we're gonna, what time is it now? Maybe 20 minutes?
Sure. How many people would you like in each room, Tiffany?
Like 5, I think.
Okay.
So
So I'll make 3 breakout rooms. We'll go from there.
Yeah, and then Brent and I will bounce around from room to room to see if you have any questions or if you need any help with it.
Sounds good.
All
I'll
right.
assign it automatically, and then I'll move you guys back out to the regular room, the big room.
Okay. Like room 1 is very engaged.
Everyone should be back.
Alrighty. Hopefully you guys had a good conversation within the groups. At this point, we were just going to take some questions, and if you had any specific things that came up that were interesting. I think in our group, Kathy brought up the point that this is kind of the first time she's thought about actually tying objectives to a topic discussion. Like, you know, we always put topic discussions to lectures and whatnot, but I think putting the structure to topic discussions is probably one of the biggest ways why it becomes so efficient.
I'll just add, I think when you're creating objectives, that is actually an important piece, because if you make them too specific or too low on the Bloom's taxonomy, like the student will just do that. Like if it's list 3 things, they're going to just list those 3 things. So like the objective creation in general, whatever application it bears, is like, you have to actually put some consideration into it, or else they could meet the objective, but it's actually, they didn't accomplish what you actually wanted as your objective.
Absolutely.
Right.
I always like to think about it too with, you know, what would be if I had a student who was coming to me to do a rotation in PICU and they've done a rotation on a ward setting, what information would I expect that student to have when they show up for the PICU discussion, and base it on that? Or if it's a PGY2 and I know that they're going to a location where they're going to be working as a clinical pharmacist in that area, if I was at that location and they were coming in, what's the baseline I'd expect them to have? So that kind of ends up guiding a lot of my objectives and the things I talk about, just to, you know, and you know, avoiding that, trying to make everybody an expert type of thing, because it's never going to happen. But, you know, having them understand basic, for a student, milligram per kilogram dosing, and, you know, what is high dose amox, and what is that, you know, just those little pieces that they're going to run into fairly frequently with regards to the population, what I call the bread and butter, or the 80% of, you know, what they're going to need to know in that area. So I think that the objectives, it's nice to have the objectives, but also to have some play in the objectives. And sometimes I'll make them a little more nebulous in a way, and that's probably not the right word to say, but give them a lot more play in the way that they're worded, so they can take it as far as they want to take it. And then if I don't feel they're taking enough, then I can ask follow-up questions and kind of push them to kind of give me more. But
Great. Well, thank you again, Drs. Pon and Dr. Hall, for taking the time to present this again to us. I think it was a fantastic group discussion and a fantastic slide set, and I think a lot of us are eager to put this into practice. Those of us who don't already do it. So I think it's really a really good discussion to have, and thank you for your time. Both of you are welcome to hop off at this point, or if you want to stick around for the second hour, you're more than welcome to do so as well. At this juncture, I will ask the group if they want to take the full break that we have in the schedule of 30 minutes, or if they want to take a quick bio break and maybe meet back at 6:10 to start off with Dr. Trinh's presentation.
Thanks, everyone.
Thank you.
Thank you. I would favor a short break to finish the evening sooner, but I'm flexible either way.
Love it. Almost everyone always chooses the short break, but I have to offer it as the option. So we'll meet back around 6:10 and we'll get going with the next presentation.
We're good? Great. All right. Hi, everyone. I think I've met most of you on the call, but for those of you who I've not met, my name is Trinh, and I'm an associate professor in the Department of Clinical Pharmacy here at the School of Pharmacy in the medication. More specifically, I'm based out of the Medication Outcome Center. So for this evening, I'm here to talk about data. I think the original title sounded like a Pokemon title, so I really should have had that as my background here. But you know, essentially all the steps pertaining to data when it comes to residency research projects, which, as Dexter mentioned earlier, is really kind of the peak of where we're at in the residency year at this point. So hopefully you'll be able to take some of the key concepts that are discussed here in today's presentation and apply it to your own research projects. One of the things I wanted to share with why I chose this background here is this is really how I perceive, research data in my own personal experience. So the first thing is that it can get really messy. One of the key things that I really encourage everyone to do, residents and trainees especially, is to really get into the data and look at what you have and see what you're working with. That's really one of the key, I think, instrumental learning steps for how to master and get better at data analysis, especially. And then the second reason I chose this photo is that it's also kind of abstract. So the more that you get into data analysis, and this really pertains to regression models and building models, it can kind of also be more of an art than a science, which was something that I wasn't expecting when I first learned about all of this and starting to build, delve into my own research. So yeah, so this is the reason why I chose this picture, but overall, the more you do it, I think the funner it gets, in my opinion. And so it can be a beautiful process if you just kind of embrace it and are willing to get your hands a little dirty. So to be consistent with the previous presenters, I am also not going to try and attempt to make you experts as much as I would love to. I think this is, the point of this and the goal of this is really to offer some practical advice for you as you are navigating this process as preceptors. And then the other key thing is that my goal is really to just equip you with enough information to make you dangerous. Meaning I want you to kind of get some thoughts percolating after this presentation and know when, know just enough to know when you need to also reach out to a biostatistician, for example. But this might come in handy as well when your residents start kind of approaching their data analysis portion of their research year, as well as when also very useful when it comes to journal clubs. Is a very useful tool for critiquing some of the methods and the results that you might come across when you're conducting journal clubs with your residents and other trainees. So here's a general outline, really divided into 3 sections. So acquiring the data. So we're going to talk about some possible data sources that are pertinent for residency research projects, how to manage your data. So this might be the step that many of you might be at right now. So recognizing how to collect and code research data, And then finally, we're going to talk about analyzing data and differentiating between descriptive and inferential statistics. So I'll start off with my very first poll, and let me see. Do you want me to launch it? I'm not sure if I can launch it from this screen. So the question is, which organization publishes official guidance and best practices for research integrity? And I think there's just a generic Zoom poll with A, B, C, D. So is it City, the City program, UCSF's CTSI, UCSF's IRB, or is it the Department of Health and Human Services?
Sorry, the poll was a little weird for a second, but it's launched now. And then I'll share the results after a little bit.
Perfect, thank you. Maybe we'll give
10 more seconds.
10 more seconds, yeah, sounds good.
All right, closing. Sharing results. Can you see them?
Yes. All right. So it looks like 60% of the audience chose A, City program, and then nobody chose D. Okay, very interesting. So the correct answer is actually D. And I can see why many of you chose City. So City is actually where we go, of course, to get our City training and responsible conduct of research and all that fun jazz. So that's just kind of an organization that houses the educational content. And then CTSI is just, kind of our research institute group here, and they offer a lot of consultations as well, but they don't actually publish the official guidance. And then nor does the IRB. So many, choices A through C are either organizations that offer the training or they kind of enforce that the training be had, but really the official guidance and best practices for conducting responsible research is really through the Department of Health and Human Services. And the reason that I opened with that is because since we're talking about data, this is kind of the many steps that the Department of Health and Human Services, specifically the Office of Research Integrity, puts out as it pertains to data. So they, they have specific guidance on ownership. So who owns the data after the project is complete, data collection. So, and it runs the gamut from just how do you collect project data in a reliable and valid fashion. And we'll talk about that as well in this presentation. But they specifically outline key steps to consider in data collection and then data storage. So this goes back to things like making sure that you keep it secure for privacy reasons and all the reasons that you specify when you submit an IRB. And then there's data analysis, which we will also spend some time towards the tail end of this presentation talking about. And then lastly, data sharing. So how do you disseminate and publish your results afterwards? And then also while you're conducting the research, if you need to share it with other people and other investigators on your team, how do you best practice go about doing that? So that's just a little primer on this group here. So before I proceed further, I do want to throw this out there that, like most things in life, teamwork really makes the dream work. And I've highlighted some MVPs that you really should think about enlisting on your team for a successful research project. The first is, of course, the clinical or subject matter experts, the SMEs, that might be you. And then you should also think about reaching out to a person with information technology expertise. And these MVPs are really crucial for being able to obtain the data for you, depending on the data source. You should also think about having a data abstractor, and that can usually be a trainee, it can be a student, a resident usually. And then lastly, someone with analytical expertise. Now, of course, these roles can overlap, but the key here is that it shouldn't just be one person. So really trying to get multiple people in a room with their respective expertise to really make this a success. And then the other key thing I want to share at the beginning is also that patience and meticulousness really helps as well, because as I'm sure you've all experienced, this can be a very tedious process. It takes a little while, and so that tenacity is also needed when you're seeing a research project through to completion. So this is kind of just a recap because I think everyone in the audience is already familiar with this, but the initial steps of a research project is, of course, to define a very clear research question. And one of the acronyms that you might have heard of is PECO. So, considering things like the population of interest, the exposure of interest, the comparator group, and then also the outcomes. You may also have seen PICO with an I, and that stands for intervention, but that's more, of course, reserved for randomized controlled trials, which we typically don't conduct or aren't heavily involved in. So usually it's more retrospective cohort studies. And so PECO is a more appropriate framework to consider. And then you also want to think about, after you've defined that research question according to the PECO format, then you want to consider the population of interest, the time frame of the study that you want to, of the data that you want to obtain, and of course the inclusion-exclusion criteria. So those are kind of the initial key steps of a research project. One of the tips that I think we really need to get into the habit of sharing and already do with our residents is start with the end in mind. And here I have an example of a table 1 from a New England Journal of Medicine paper several years ago. But this is a really good example here of to get in that we encourage our residents to take a look at when they are first starting with their data collection tool and designing it, is look at the existing literature and see what others have reported, what others have collected. And this really helps to helps them kind of focus in on their data collection tool and designing it. So this is a really good example to go off of, and helps them learn as well, and in terms of how to focus what they're going to collect. And then once you have that in mind, then you want to consider, okay, what is my, what data source do I want to use, a primary or a secondary data source? And there are examples on this in this table here that you can see of primary data sources and then secondary data sources. So on the left, primary would be things like observations that you make yourself, surveys and questionnaires, so some more qualitative types of data here, interviews, as well as focus groups. And then the secondary examples include things like proprietary resources, so electronic health records such as APEX, administrative claims data from any of the health insurance companies. And then there are also publicly available data sets as well. So things from health departments, both local and national, as well as some national organizations have some freely available data sets that you can use. And then, of course, there's always the option of using and collating prior studies to publish things like systematic reviews, plus or minus a meta-analysis is another source of data that you can consider. Some example data sources are listed here for you, and I have the links available, but essentially they range from data.gov all the way to the CDC, ARC, so the Agency for Healthcare Research and Quality also has some nice data sets that you can purchase. And then the FDA also, of course, has the adverse event reporting system, as well as the vaccine adverse event reporting system data that you can use. And then state and county public health departments have their local data that might be accessible. And I've added some examples of health systems data, as well as commercial claims data that are available as well. And the nice thing about these is that some of them, such as Vizient or Optum Labs, they do have information on both inpatient as well as outpatient stays. So that's a nice, resource to consider if you're trying to capture kind of the whole patient experience from both acute and also chronic perspective. But of course, these do cost money. So then that leads me to, what are the considerations that you should keep in mind when deciding which data source to use? Of course, the first is budget, because as you saw on the previous slide, there, data sets can range from freely available to cost thousands of dollars for a data set. So for example, the Premier or the Optum Labs ones are like $50,000 to access, depending on how much data you want. So really, that's kind of the first and foremost important thing. And then you also, of course, need to consider budgeting for a programmer. if the data is something that requires programming to access. And then the second consideration is time. So you want to account for not only the time to pull the data, but also time to manage and wrangle the data into a workable form, or dreadfully, even manually having to abstract it from things like the electronic medical record, which I think we're mostly familiar with. The third consideration is quality. So you want to think about the data quality that you're looking for. Things that can affect quality are things like sample size. So if you really need a larger sample size, then perhaps certain data sets aren't ideal. And then also data granularity. So one of the things that I think is pertinent to our group is that a lot of the claims data don't have medication administration times available. So they have fill data, but that doesn't, as we know, always necessarily correspond to the patient taking the medication per se. So that can be tricky if you're really trying to get more granular and look at medication administration times. And then lastly, privacy is the other consideration to think about, and things like data use agreements to obtain the data is a factor, and that can also affect the time. So building in that time to be able to obtain the data after sending in the data use agreements and things like that. So these are kind of the considerations when you're kind of looking at all the various resources available in terms of obtaining clinical data. So then that leaves us with kind of something that we definitely should talk about, which is the most readily accessible data source that we have is probably the EMR, so Apex or Epic. In this case, we really want to collaborate with your information technology team to obtain the data. And then when you should approach the team, you should really clearly outline your needs. So things like the research question, the population of interest, the data elements that you have in mind that you'd like to collect, as well as the project timeline. So including things like IRB approval ahead of time. And then I also just want to, I think everyone's aware, but there are differences, of course, between a fully identified data set versus a de-identified set and then a limited data set. And these are things that come up in the IRB as well. So just language for you to be aware of and look further into to see if perhaps one of the lower, like a limited data set is more easily obtainable. And so that might, if that serves to answer your research question, then that might be good enough. And then you don't have to seek a fully identified data set, for example. In terms of the data abstraction process, so when we're talking about navigating the EMR and kind of manually or even automatically pulling the data, some of the things that we have to keep in mind, and even when you automatically pull data, you might not be able to get, depending on your research question, might not be able to get the granularity that you're looking for, and might still need to QS with a little bit of manual chart review. And so in that case, one of the key things to do and key steps that are involved is really first to develop the data collection tool. So going back to the tip before of starting with the end in mind, you want to identify the data elements that you'd like to collect and then design the tool. And then once you've designed the tool, then you really want to, of course, also build in a code book or a data dictionary that helps with if there are multiple data abstractors who are going to be helping with data collection. And then, as we know, then you want to definitely train the abstractors so everyone is collecting data reliably and consistently between each other. And then you can pre-pilot the form and make modifications based off the pilot. And what I mean by this is, maybe you want to go through 5, 10 patients and then readjust and look and see if the data abstraction abstractors were consistent between them. So maybe assign the same 5 patients to 2 data abstractors and see, and make modifications and then implement the form. So of course, this goes back to the whole patience and meticulousness piece earlier. This does take a little bit of time on the front end, but if you are able to put that effort in, then I think it does really pay dividends in the end because the data are collected in a more consistent manner. And then lastly, you want to routinely just assure data quality by doing things like exporting the data at a certain time frame to monitor the data quality, and then of course adjust the tool as needed as well at that point. So the goals of reliable or of data abstraction and good data abstraction is to make sure that there's reliable data collected, so data are collected in a consistent manner, and that it's also valid, meaning it's accurate. And so I think we've definitely all seen this, these figures before, but essentially our goal is really to be in the last target bullseye here. So not only are we accurate because we're getting the darts all in the bullseye, but also reliable because we're consistently able to get it into the bullseyes. So that's really the goal, and that's why the training and the code book really comes in, is really important when you have multiple abstractors on your team. Another tip on how to maximize data abstraction and to minimize data entry errors is to use a tool or a program such as Redcap, which we have freely available here at UCSF. And the reason that I like Redcap, even though they're not sponsoring this talk, but just a huge fan, is that, they offer things like HIPAA compliance, and it's accepted by most IRBs as a reasonable data abstraction, data collection form to use. And then you can have multiple export options, including Excel, as well as export options and files from most statistical software, such as SPSS, SAS, Stata, and I think they have R as well. And so the other nice things is that if you've had a chance to play around with Redcap, you'll see that there's, you can have branching logic. You can really specify the variable fields. So ranging from free text all the way to numeric values only, as well as date and time values. So you can kind of really restrict the information that's entered, and that kind of helps with minimizing data errors as well. There's other options that to help minimize errors as well, that include things like radio buttons or drop-down menus that limit you to selecting only one choice. And then there are checkbox options, which allow you to check multiple choices at once. In those cases, one of the things I recommend doing is also include an other option as well as none of the above options, just so you know that, just in case all of your options aren't listed, then the abstractor has the option to enter other and then maybe branch it out to a free text so they can specify what that other is. Whereas the none of the above options, it allows you to kind of make sure that that question or that data variable was evaluated. So a good example is like comorbid medical history. If a patient, younger patient probably doesn't have any chronic conditions, then you want to make sure that there's a none of the above option at the end so that you can check that off. Otherwise, when you're exporting the data, it might look like maybe that variable was skipped for that patient when in fact it was supposed to be none of the above. And then lastly, be patient again and pay attention to detail because abstracting quality data really takes time. And with most things in research, the quality of your output is really dependent on the quality of your input. That whole garbage in, garbage out really applies to research in this case. So talked about Redcap and just showing you an example here of kind of the various different options that are available. So on the left, you can see when you're designing the Redcap, you can select the field type. So things ranging from text box all the way to checkboxes. There can be visual analog scales. So myriad options for you to choose from. And then this is what it looks like on the right-hand side. So you want to specify the variable name. In this particular example, it's date of birth. So you can see that in terms of the validation option here, it's date only in terms, and it's to be represented as month, date, and year. You can specify whether it's required for data collection, whether it's again, an identifier. So going back to that HIPAA compliance piece, and then so various other options. So this gives you just an overview of kind of the options that you have when it comes to Redcap. Excel is another commonly used option. I don't recommend it, especially if you have a larger data set, just because it can get a little bit messy if if data are transposed incorrectly or sorting errors happen or things like that. And so really keeping it with Redcap would be a great option that I think to recommend. Just checking in the chat here.
Sorry, it's just me. I was just adding on that Redcap is super useful for multiple data collectors.
Yes, thanks, Dexter, definitely. So lots of benefits to using Redcap, and would highly recommend, kind of taking a little bit of time to learn about it. I don't think the learning curve is too steep. And then there's just always very great informative videos on YouTube to help you as well. So now I think this is the only breakout room discussion for this talk. And I think I just want to have maybe 5 minutes for everyone to share and exchange your successes and pain points pertaining to 1, data acquisition, and then 2, data collection, which is kind of the 2 key steps that we've talked about so far.
Trinh, it looks like you already got them designed up. So,
oh, great.
Do you, or do I have them? I must have them.
I don't. Nope. Yeah, I cannot see anything on my end. Actually,
I'm just gonna do 2 rooms since I have a smaller group. Yes. Opening them now.
Great. Okay. And I don't think this is one that search projects possibly. And then the other one is Vizient, of course, that has some challenges in terms of getting the data, but at least it's freely available. It's just more of time built into getting the data. It looks like Kathy has a question.
Yeah, it's partially a question, partially a comment, and just this in our work. Challenge I find when sort of dealing with data and learner projects is where to effectively house it so that it's accessible, encrypted, shareable if you have a project that multiple people need to actually access. I know you had mentioned Redcap is great for, I think that's maybe more for the inputting of the data. I don't know. I'm not an experienced or savvy Redcap user, but it's once you actually have your data set, does it go in Box? Does it go in a shared drive folder? Just one of the logistical pieces of physically or technologically how to store it so that the people who need to get it can get it, but that it's not putting you in risk of having sensitive information in the wrong hands.
Yeah, that's a great question, Kathy. One of the resources that we have at UCSF is a thing called My Research. And that is something that everyone with a UCSF email and My Access login can request to have set up through IT. And then once they set that up, that's actually where CTSI, if you go through CTSI to get your data pulled, that's where they will actually put the data. So they will actually not will not even start your project until you have a My Research folder set up, because that's where they can securely, kind of deposit the data for you. And that's how you can add learners to your project, your My Research folder, and they can access it that way as well. So that's kind of the recommended way to do it. And then the other thing that I'll also share about Redcap is once you get the data set, pulled, if you can actually re-import that into your Redcap as well. So that might be an easy way to not have to recollect any of the information that was already pulled. And the key is that you just kind of have to make sure you rename the variable names to match what's in the file that was given to you, as well as what's in Redcap. So as long as those 2 file variable names match, then it should be able to re-upload and be re-imported back in, no problem. So that's another reason why, highly advocate using Redcap whenever you can. Let me reshare my screen. Great questions. Were there any other questions that came up in the other room? Okay, well, feel free to pop it into the chat if anything comes up as I present, but then we're going to proceed with kind of like the last portion, so talking about data analysis now at this stage. So some data analysis programs that are really, commonly used ones are listed here on this slide and in this table, and the advantages and disadvantages of each of the programs are provided as well. So I think we're all familiar with Excel. It's really easy for most beginners. One of the nice things is that there's a perpetual license and it's relatively inexpensive to obtain. The disadvantage is that it's limited in terms of its not only data management capabilities, but also its statistical analysis capabilities. There are add-ons for basic stats, but compared to the other programs, it's not as robust. And then I would say SPSS and Stata are probably the two that are also relatively easy for beginners / intermediate. The reason for that is that both programs offer point and click options. And so if you don't want to be coding, you can use SPSS and Stata to just point and click and pick your tests that you'd like to run. Unfortunately, both require a license as well. The nice thing is that Stata has a perpetual license, and you can, and I think you can have like multiple users as well. The only the downside with SPSS is that it's just a yearly license, and so it expires every year, and you have to just repurchase a license every year. SAS and R, I've included on here for completeness sake, but those are really kind of more advanced with really, really steep learning curves, more so R. But the nice thing with R is that it is freely available. Yeah, requires coding, and you might not always know where your code went wrong because it just won't tell you. But your test just won't run and you have no idea why. So really steep learning curves with those programs. So the reason I opened with that, that table of all those different programs is then not only are they good for running stats, but also for managing your data. And I know this came up in our room about the challenges with, data management and data cleaning, that's always a tricky step when it comes to learners. And so this is kind of like a quick, non-exhaustive list, of course, of kind of the key things that I do when I get a data set and how to clean it. So the first thing is removing duplicates. That's pretty straightforward. You can do it with any of the programs. The second thing, and I have slides for each of this, but is to visualize your data to identify any outliers and also illogical data. Then you want to do things like maybe manipulate the data set itself. So you can change the data layout from long versus wide, and I'll show you examples of that. You can also merge different data sets. So sometimes if you work with CTSI or other groups, when they pull even just Epic, Apex data, they come in different tables. And so they're actual different files. And you have to merge them together based on one unique identifier to get your master data set, if you will. So merging data is another data management step that I also like to do. Transforming data elements is also another step, and then addressing missing data. So we'll talk about all of these in detail here. Visualizing your data, I think everyone, you hear this a lot, is you just have to see what it looks like. You have to see the distribution, the histogram. And this is a really great way, whether you do it by the frequencies table, which is what's on the left there, or by the histogram, which is the figure on the right. It gives you a quick visual of what your data looks like and your and to identify outliers. And this is a great way to identify errors in data entry. So if your project involves a lot of manual data collection, then this is a great way to check for that. And then you can just quickly, pop into the record and fix like the age or something. If somebody is like 900 years old, you can quickly fix that. So always, visualize your data first so that you don't spend too much time with the higher level steps and then realize that your data set wasn't as clean as you would have liked, or there were errors that you could have easily fixed. The second data management step, or one of the other data management steps that I like to do, is also changing the data layout. And so what you'll see here is there's the long data set, and and I just remember as long and skinny or short and wide data. And the examples are beneath each of the two columns there. So you can see that the long data set has multiple records or multiple lines for the same patient. So in this case, in this example, there are 3 unique patients as exemplified by the patient ID. But then you can see that for their diagnosis, they have multiple diagnoses. And so each diagnosis gets its own line. Compare that to the short data set. So 1 record or 1 line per patient. And you can see that each of the diagnoses become their own columns. So the data set gets a little bit wider. This is often how data will be provided to you, whether that's data provided to you by, your informatics group, CTSI, whatnot. Also how data will be provided to you when you export it out of Redcap. Which is another tip when using Redcap and piloting it, is try to enter a few patients, export the data out to see what it looks like, via Excel or via any of the stats programs of your choice. But oftentimes it's laid out in more of a wide fashion. And this is really most common and the preferred way for data analysis, is really to get it into this wide fashion. So if you're ever given data in long form, you really want to change the layout to short form. Another data manipulation tool is to merge data sets. And so there's 2 kind of different ways to merge data sets. There's either the one-to-one, which is on this slide, or the one-to-many, which is on the next slide. And essentially, it's really taking 2 data sets with different data elements. So in this example here, data set A contains the sex and admit date, and then data set B contains the 3 diagnoses in the separate columns. You'll see there's 1 unique patient identifier for both data sets. And so that's the variable that you're going to merge on. And once you merge the file, what you'll see is that it kind of tacks on data set B to the end of, it appends to data set A. And so you just see this wider data set by combining the 2. So that's the one-to-one option. The other option is one-to-many. And this is when you're taking 2 data sets with multiple elements and you need to merge them based on, again, that 1 unique identifier. So in this example here, you'll see in data set A, nothing's changed, 1 row per patient. But data set B has the diagnoses. Each diagnosis is a separate row for the same patient. And what happens when you merge on that 1 patient ID unique identifier is that you can see it creates a long form here, so that it's not, so that each row is a separate diagnosis. So after you do this, then you can convert the data set to a short form, which makes it easier for analysis. Many of the programs, the stats programs, the common ones, like using short form, and it just makes more sense because you can just select the variables that way, whereas it does not really like when you have multiple rows or the long form of data. The other thing you can do is transform data elements. This screenshot here is an example of a menu from SPSS. And so I've just kind of have arrows pointing to some key transformation tools that I like to use. And so things like computing a new variable. So for example, if you wanted to if you had a continuous variable, let's say age, and you wanted to either dichotomize them or categorize them into different categories like 18 to 25, 26 to 30, etc. You can do that by computing a new variable. So you just tell the program, the age field. If age is 18 to 25, then new variable equals 1 or yes, and things like that. So this is a great tool to use if you just need to manipulate your data, your existing data set in any way and create some new variables. In that particular example where I just said to dichotomize or categorize your continuous variables, you can do that. And the reason people do that is to report categories and things that make sense. In general, when it comes to just statistical analyses, generally it's better to feed the program the actual continuous data, so the entire age range that you have in your data set versus these categories that you've computed, just because there's more data points available when it's in its continuous form. And just in general, math likes more data and more numbers fed into the models. And so whenever possible, try to keep your continuous data intact and not categorize them or break them apart into different categories. The second thing to do that's from the same menu is things like recoding. So you can recode into different variable, or you can recode into same variable. It's exactly how it sounds if you're not familiar with this. So if you want to recode something into a new variable, so for example, this might be a good example of this is like, let's say you have race in one column and you have, of course, multiple races. If you wanted to create a new variable and say, Asian 1 equals yes or 0 equals no, then you can actually have multiple columns into different variables that represent each of the races. So this really works well when you have categorical data that have different, levels like that. You can also, of course, recode into same variable. And then there's also, depending on how your data is structured. And again, this is going back to getting into the data, getting messy. There are things like string and numeric. So, if your data comes through as text and you need to, let's say, convert it to numeric for easier analysis, then you would be able to do this via recode. So things like the binary, 0, 1, yes, no. Sometimes if the actual variable field is a yes and it's a text, the background is interpreted as a text field, then programs, the stats programs won't be able to analyze that. So then you have to recode and convert it to a numeric value. So these are some of the options that you have to play around with when you're going into the data cleaning phase of your data set. Another option is dummy variables for nominal data. Again, a good example of dummy variables is, they call it this, but it's just a name. But again, when you have multiple categories within a nominal variable, then you can break it out into different, its standalone columns. And then that way you can analyze that variable. So for example, race, you wouldn't necessarily just put race as a covariate into a model by itself. You'd have to kind of break it out into each one. So Asian, yes, no, Black, yes, no, white, yes, no, things like that. So that step to transform your data element is called creating dummy variables. And then date and time manipulation is also a good tool to use. And this is when you want to create or calculate things like length of stay between your admit and discharge dates, for example, or other things. You can do that with date and time manipulation. And date and time, you can also, or these calculations, you can also do on the front end during data entry with things like Redcap. So you can have calculated fields when you have two dates input together, and you can calculate the difference between them. The last thing is how to address missing data. So when you're visualizing your data, you might also be able to tell whether some, or when you run the frequencies table on a variable, you might be able to tell how many of them are missing that variable, how many records. And so in that case, there's various options on how you want to proceed with that. It depends on what the variable is. If it's something really important, like maybe it's your primary exposure of interest, you probably want to go back and manually abstract that data from the EMR, for example, and that's the first option. But if it's something that is not as pertinent or necessary, then perhaps you could consider something like recoding it into an unknown category. You can accept that it's missing altogether. Other things include also imputing and dropping, both of which I would say consult your biostatistician whenever you're considering doing that. Just imputing is a little bit more difficult of a step to do. And then dropping, the reason you want to consult them is because then you're just really losing that entire record, right? And so it might not be worthwhile to drop the entire record based on one missing variable from that patient, for example. So proceed with caution is really reserved. Dropping it is really reserved as a last resort option, because you want to really maintain as much data as you can, valid data as you can in your data set. Okay, so we're going to launch into our second poll. So this question here is, which of the following is a continuous variable? A, number of children in a family. 2, or B, age. C, discharge disposition. Or D, an Apache 2 score. All right, great.
Ready to see results?
Yeah.
Oh, you got it.
Thank you. Yes, so you're absolutely, all 5 of you are correct. Age is a continuous variable. And then we'll talk about kind of the 2 other quantitative types of variables there. So number of children in a family, and then Apache 2 score, and how those are categorized. Discharge disposition is pretty straightforward. It's a nominal type of variable. So definitely review for all of you here, but in this slide, this is really helpful for our learners to, because sometimes it can get a little tricky, especially again with the quantitative variables there. They can either be continuous or discrete, and then examples of continuous variables, again, like height, can in theory take any value within that given range. And examples of conversely discrete data are things like number of children, number of asthma attacks that you have in a week, for example. Those are count data, so very discrete. And then the second type of data type that you have is categorical, again, so nominal versus ordinal. Not going to belabor the point here because I think we all know the definitions of this. The reason I included that slide is really to set us up for, it's important to know those details so that you know which appropriate test to select when you are running the analysis. So general steps for analysis, we talked about this already, formulating a hypothesis. You can't really do too much stats if this is not a hypothesis driven research question. So things like prevalence studies or exploratory describing the prevalence of X disease in, in Y population, that would be more exploratory, probably aren't going to be comparing anything because you don't have a comparator group. So in that case, this is really reserved for hypothesis-driven research. So you've done that, then you've obtained and hopefully now clean or manage the data using some of the programs available. And then, so now we're talking about selecting an appropriate test and performing the analysis at this stage. So one of the nice things for learners is to, ask your residents to develop a table with the types of variables that they're planning to collect or obtain, and then ask, what is the associated test to use with that. And I think most of our learners really enjoy this activity, but this is a really good way for them to solidify these concepts as well. And so there are 2 main analysis types, of course, descriptive as well as inferential. Descriptive is exactly as it sounds, organizing, summarizing the data. It's typically what we would call like our table 1. And you often see this presented as charts, so pie charts, bar charts, as well as tables and histograms. It's reported in the tables as frequencies and percents, as well as some other measures of central tendency there. So like means, medians, modes, things like that. It's very appropriate to use descriptive stats, again, for things like exploratory studies when we really don't have an idea of what's going on. So prescribing patterns, for example, you don't really have a hypothesis there as much, and you're just really trying to take that first step of understanding what the current situation is. So that would be a prevalence study and highly appropriate to use descriptive stats in that case. Inferential statistics is when you're really trying to make inferences about the larger population from the sample of which your data were obtained. So hopefully the samples were reflective of the entire population of interest there and sampled appropriately. And then kind of the two last bullets on the slide here is where we'll be spending the time, the rest of the time. But when it comes to, outside of the descriptive stats, after you do that, then really the next steps are to conduct a bivariate analysis, and then correlation or multiple regression analyses thereafter. So we'll talk about those shortly. How do you select the statistical tests? So this slide is really for completeness sake and coming full circle. Some of the questions that you want to consider asking is your learners is, are the data independent? How do you generally tell? In general, data is independent if the results are not from the same individual. Or they're not from matched individuals. So as long as they're not matched or they're not from the same individuals, then they're independent. And matching is also a little bit tricky in the definition here, because let's say you're matching based on a variable such as age. So you're matching patient A, who's 25 years old, to patient B, who's in the other treatment group, who's 25 years old. Even though they are separate patients, because you're matching, then in that case, it becomes dependent. The data become dependent on that one variable. So in that case, you would treat that as dependent. So just a little note there about that point. And then what types of data are being measured is the second question that you want to ask. So there's different tests. You've seen the tables for the different tests that you would use, but they differ between the matched paired types of data versus the independent types of data. And then you want to determine the data type not only for your exposure of interest or your independent outcome of interest, but you also want to ascertain the data type for the outcome of interest or the dependent variable. Those are two key ones to look out for when you're determining which test is most appropriate to use. And then lastly, specifically for quantitative data, you want to consider the distribution as well, because this comes into play when you're selecting between the parametric versus non-parametric test to use. And that's just going back to whether the continuous data exhibits follows the bell-shaped curve or the Gaussian distribution. So now we'll talk about the bivariate analysis. So I'm going to take a pause here and let you take a look at this example table. A little more up my alley with ID, but in this particular study, they're looking at two treatment groups. So those among patients who have MRSA bacteremia, so patients who got vancomycin monotherapy, compared to patients who got a combination of vancomycin and cefepime. So you'll see kind of the demographics as well as other factors and covariates on the left-hand side, and you'll see p-values on the right-hand side. And the question for everyone is, and you can pop this in the chat or unmute your mic, but what is your conclusion from this table one?
For me, Trinh, all I can do is look at the different demographics and just say that patients are generally older in the combination group. They generally have more dementia in the combination group. But other than that, I can't really make too many conclusions.
Yes, thank you, Dexter. That was not planted, but yes, not much. Can't really make, you can't really infer too much from this, because the next step is then to do a regression in order to fully confirm any of these observations here. And the reason for that is that we need to adjust for these confounders. So as you can see, it looks like dementia was higher in the group that got vanco and cefepime. Also MI looks like it's significant, but aside from that, you can't really say much from this. One of the things I want to also bring to your attention here is that this is our typical table one. So what that means is we're showing here the exposures of interest or the treatment groups of interest, the comparator groups of interest, and calling that a table one. The key thing to keep in mind is that the data that are presented in a table one like this, where it's only the treatment groups or the exposure groups that are shown, that's just for information only. None of the variables that are shown on this slide here and are the ones that should inform your regression model. And what I mean by that is you really need to make, more or less a table 2, if you will, wherein the columns and the comparator groups are your outcomes of interest. So in this particular case, I believe it was microbiologic failure with the MRSA bacteremia. And so you would have this column be those who experienced microbiologic failure, those who did not. So those are your outcomes of interest. And you would recreate this whole thing with all the demographics and see their associations with those outcomes. And so that's a second bivariate table that you could create an analysis that you would run. And those would be, any of those that are significant, which is not usually based on a p-value of 0.05 when it comes to regression model building, but it's a little bit more relaxed. So something like 0.2 is, oftentimes the p-values that are used. If any of those covariates are significantly associated with your outcomes in this bivariate table with a p-value less than 0.2, those would be what you would consider as candidates to enter your regression model. So the reason I was expounding on that is because oftentimes that table, this bivariate table, doesn't get shown or reported in the manuscript or in the journal. And so this is really what's shown. So the treatment groups and the differences between them, but that doesn't really offer much value, because if you're a purist, when you look at a regression results table, you want to know what were the candidate variables that could have been considered to enter the model. So just a little, minor detail to note, but it's really important when you're running these analyses to consider that. This is what everyone likes to see, but what really informs your regression model building is actually a bivariate of the outcomes. So the differences in outcomes is what we're looking for. I spend all of that time to then summarize with kind of some of the different regression models that you might encounter or that are pertinent to most research projects. And this is simplified. Oh, I realize there's a chat. Oh, thanks. Yes. Overall, 2 groups were well matched, definitely. Larger second group, yep. And yes, you'd want to know if the study was powered appropriately and confidence intervals, yep. Yes. So all great points with that table 1. So once you have, this, but with the outcomes of interest, then you can start seeing, there are maybe some confounders that I would like to possibly consider when I'm building my regression model. And so when you're choosing your regression model, again, very overly simplified, but I kind of selected the ones that you're most likely to encounter based on many of our projects. So first you want to look at the independent variables or your exposures of interest or your covariates, and then also look at the outcome of interest. The independent variables don't change. You can have many variables in your regression model, and they can be quantitative or categorical in nature. Then what changes and what really drives which regression model you choose is actually the dependent variable or the outcome. So if your outcome is continuous, so something like length of stay, for example, in days or in hours, what have you, then you would use a simple linear regression model. If it's a time to event, so time to anything, time to death, time to cath, time to MI, whatever that event is, then you would use a Cox proportional hazards model. And then if the dependent variable, and this is, I think, the most common, is a binary outcome, so usually like mortality, dead or alive, then you would use a logistic regression model. And then lastly, if you have more than 2 levels in your categorical data, then you could consider using an ordinal regression model. The other thing that I think is really important to point out is that the terms, multiple or multivariable regression analysis is usually what we do. And it's it's pretty simple, and it's everything that's depicted in this table here. It's when you have multiple independent variables, but one outcome. And that's, again, really common to what we do. On the other hand, multivariate regression analysis is a lot more complex and probably definitely would need a biostatistician involved, is when you have multiple outcomes. So oftentimes we actually don't do or conduct multivariate analyses, but you'll see this sometimes in the literature where the study group will say that they've conducted multivariate regression analysis when really it's actually multivariable regression. So just another little minor detail, but important when it comes to the methodology. Then in this table here, you'll see there's from the same study from earlier. So this is the multivariable logistic regression table. And this is typically, depending on who you talk to, sometimes you'll see, I think the purists want to see all the variables that were considered for that were considered to enter the regression model. And then others might just say, I only want to see what stayed in the model. So like the first four here stayed in the model. You can see here that the adjusted odds ratio is in the setting of all of these, covariates. This is what the adjusted odds ratio turned out to be. These other covariates were kicked out of the model when they were adjusted for each other. So different ways to present the regression model results, but most people, myself included, and I think most of us would like to see what else was considered and what was kicked out, what was not significant. This is, again, where I go back to the beginning of this talk, which is that this is more of an art than a science. And the reason for this is you can imagine it's not as simple and straightforward as saying, let's conduct a bivariate analysis based on the outcomes and see which covariates have a p-value less than 0.2, and I'm going to put all of those into the model. The reason for that is that you can overfit a model, and that gets into, so you can't just put a bunch of different variables into a model. It's based on things like your outcomes. So how many events did you have in your cohort? And that number allows you to kind of better determine how many covariates you should consider including in your model so that you don't overfit it. You can tell the model fit because when you run the stats, it'll spit out, a model fit number, a statistic, and you want it to be non-significant, which in this case it is. So you can see that this model was sound and you can kind of trust the results. But this slide really was trying to depict that different ways in which you can, report the results of a regression model, the importance of, understanding that it's more of an art than a science. And then the other thing I'll also share is that the odds ratio that you see here, the 95% confidence interval should correspond to this p-value that you see in your bivariate table. So what it just means is this is essentially your p-value for in your bivariate table when you look at vanco plus cefepime versus vanco alone on microbiologic failure. The adjusted odds ratio is what we care about when we do the regression. And so in this case, you can see it looks like the combination of vanco and cefepime, at least in this cohort, was significantly associated with a 50% decrease in microbiologic failure. So those who got vancomycin, 50% lower risk of experiencing microbiologic failure in this case. I think that was all I had for this slide. But again, a lot of information. I think the key is just, this is where you're enough information for you to be dangerous is knowing this. This is at the point, I think, at the stage where perhaps consulting with a biostatistician on how to best build the model comes into play, because there are so many factors that to take into account when you decide, which variables should I include? How do I go about including them? One of the things that I always like to do is let's say I was only able to choose 5 covariates to put into this model, but maybe 10 of them were significant on the bivariate. Again, significance meaning like a p-value less than 0.2. How do I choose? How do I choose which ones to put in? So factors like biologic plausibility comes into play. One of the things I commonly see would be ICU status. So the location of the patient at the time of, let's say, positive blood culture. Am I really going to put that covariate in when maybe Apache 2 score is also a covariate that I'm considering? Would that be a more reasonable covariate to put in rather than, location of the patient at the time? And that goes back to the biologic plausibility piece. So if the patient is, sicker, is it more likely to be associated with a worse outcome? Is it potentially a confounder? So I'm going to want to put the Apache 2 score when I have a limited, space to consider for covariates. Then I'm going to choose the Apache 2 score over ICU location or bed or unit stay or whatever at that point. So that's, again, illustrating that it's more of a little bit more of an art than a science, but I like to build a lot of these models. So I like to run these many different ways. When I have limited numbers of covariates that I could put into the model, then I'll just run various combinations of them, mostly driven by biologic plausibility. And then I will look at the model fit numbers to tell me which model, was really the best. And so when you're doing this a lot, you're right. You're literally writing down, model 1, I considered these variables. This was the model fit. Model 2, I considered these variables. This was the model fit. And at the end, you're really looking at all of it and saying, which one makes the most sense? Which one explains the data that I'm seeing? Which one explains the observations that I'm seeing? And that's the one that gets reported. So again, that's really was, a little bit strange for me to come to that conclusion that it's really more of an art than a science. But, the model building is just whatever the quality of the model is really dependent on what you put in. So that is the last time I will harp on that whole art and science thing. And so to summarize kind of the key steps, again, formulate the hypothesis you obtain and clean and manage the data, and then select the appropriate test and perform the analysis, not stopping at just descriptive or bivariate analyses, but proceeding on with an appropriate regression model as well. And then in summary, you always want to consider, of course, your budget, time, the quality of the data that you need, as well as any privacy restrictions in place when deciding which data source is most optimal to answer your research question. Use a standardized data collection tool or form whenever possible to increase the likelihood that the data is reliable and valid. And then you want to conduct statistical analyses that not only include descriptive stats, of course, but also bivariate analyses and multivariable regression analyses that fit your data. And then the last audience poll question. Can you conclude whether a significant relationship between X and Y exists based off a bivariate analysis alone?
Everyone's shy. Oh,
Yeah.
They have some answers.
They're just really thinking about it. Okay. Yay, thank you. This is more a reflection on me than it is of you. So I am glad to see that I've harped on it enough that no, you should definitely conduct a regression analysis whenever possible. The reason why this question is here is just because I've definitely seen many times where, time and time again, where erroneously, learners would conclude that an observation is significantly associated just based off the bivariate alone. So this is where we really can augment, I think, their learning by taking it to the next step with a regression analysis. Great. And I will close with some resources that are available here at UCSF. So the library definitely offers, many workshops, and you can actually subscribe to their Data Science Institute listserv, which informs you of the workshops that they have upcoming. And then CTSI also offers the free consultation hour for trainee projects. And it can range anything from consultation with study design at the beginning to data management and all the way through to statistical analysis. LinkedIn Learning is an option available through UC Learning that I just learned about as well. And so, I think they have some nice, good stats types of classes if you're interested. And then of course, good old YouTube. This is really helpful, I think, for specific stats programs. So when you know what test you want to run, but you're not quite sure how to find it in your program menu or the code, YouTube is always a good resource as well. And Google, I should add, for finding that information. And so with that, I will close and ask if there are any questions. Thanks, Amanda.
Seeing no questions, I will say that this is a wonderful session, and thank you, Trinh, so much for giving it. I think not only was it excellent being here live, but having this available recorded for some of our other preceptors will be really, really useful in the future. So thanks so much again for giving this. And I echo the thoughts, I'm sure, of everyone in their head that this is a great, great review and expounding upon things that I think about often, but don't really have the answers to. So I think it's very helpful to have this. Thank you so much, Trinh.
Thanks for having me. Have a good night, everyone. Happy holidays.
I guess.